So ATTR amyloid is what we'll be talking about, which is cardiac specific amyloid. But as Ian's mentioned, there is also amyloid that occurs from multiple myeloma, or AL amyloid, and we'll talk very briefly about that. So as Ian may have said, what is amyloid? So amyloidosis is a condition where normal proteins that are made in the body that are circulating, usually in tetramers, change shape due to some sort of a mutation, either a genetic mutation in the production of that protein, or some sort of a dysmorphism that occurs that causes them to clump together. So proteins that should be in tetramers suddenly start to clump together and form bizarre shapes. Once they're stuck together like that, they form these weird fibrils, so proteins that are just not aligned properly, and then because they're not aligned properly, they're not doing the work that that protein was supposed to do, and then it starts to deposit in all sorts of organs, which then starts causing damage to different organs. Okay, so amyloid is a systemic process. It affects the heart. That's why we're focused on it as a cardiac center, but it affects other systems as well. And the reps that are here from Amylin will be talking about a treatment that they have developed for the neuropathic components to it, which are actually a significant component of the disease burden, but I'll talk a bit more about the cardiac part. So this abnormal protein starts to deposit in other organs, and then it starts to cause damage. Now, this, as I said, can be a genetic disorder. It can be inherited within families. It's seen most commonly in the African, Canadian, African American, the Caribbean populations, but there are clusters in other parts. It can also be a point mutation in that individual, so it doesn't necessarily have to be genetically inherited. And then there are other inflammatory or chronic conditions like dialysis that can also increase the rates of amyloidosis due to abnormalities in protein handling in those conditions. So there's certainly multiple mechanisms through which amyloidosis can occur. As I said, it affects multiple organ systems. We focus on the heart, but the fact that it affects multiple organ systems actually gives you a clue as to the diagnosis of who should you actually be screening. When you see cardiac patients that have other conditions, it should be something that you start thinking about. So what are those other conditions? It can deposit in your kidneys and you develop renal failure. So, cardiac hypertrophy, heart failure patients that have concomitant significant renal dysfunction, you want to think about, is there a possibility this could be amyloid? It can deposit in your tendons and in the sheaths in the arms, and they can get carpal tunnel syndromes. That's a common presentation. So again, if a heart failure patient concomitantly tells you, oh yeah, I had carpal tunnel surgery in both my arms before, again, just a red flag to start thinking about, could they have this abnormal protein that's depositing in their heart? Okay. They can develop neuropathy, so it starts to deposit into the actual nerve bed, into actually not necessarily the nerve bed, but into the vascular beds around nerves. That starts to compress the nerves, injures the nerves, causes a lot of nerve irritation. So again, heart failure patients that start complaining of numbness in their feet, having difficulty sensing, it's often a sensory neuropathy, so losing sensation in their feet, suddenly losing muscle function, things like that distally, all potential clues that we may be dealing with a systemic process that we should be thinking about, and then at least start thinking about screening these patients for amyloidosis. So as I said, it can affect multiple organ systems. It can affect your eyes, can cause glaucoma, it can cause hepatic enlargement, it starts to deposit into the liver. It deposits into the GI tract. They often will have a lot of GI side effects, but often some of the clues, as I said, are carpal tunnel, concomitant renal dysfunction, neuropathy. It can actually start to deposit into the brain, although intracranial amyloid is very different. So the amyloid that you see, for example, in Alzheimer's is not the same type of amyloid that occurs in cardiac amyloid. So certainly something that we need to start thinking about when there are patients that have multiple organ systems involved. Now, how does it affect the heart? Well, it affects the heart because the fibrils, these abnormal proteins that should have been going around doing whatever work they're supposed to be doing, are now depositing into the heart muscle. It's causing the heart muscle to thicken, and as it thickens, the thickening is actually fibrotic tissue that's starting to develop. So as it thickens, it now starts to stiffen the heart. So it is a form of heart failure with preserved ejection fraction. So they'll present with HFpEF, Now, if it's left its own device, not treated, over time, it will actually cause continued scarring in the heart and then ultimately lead to dilation. And then they will ultimately develop a dilated cardiomyopathy and then HFrEF. But that's really getting into the end stages. We want to catch these people much earlier. We still try to treat those patients. And the first patient that Ian was talking about that we started on treatment with tafamidis actually had gotten into the dilated stage of it, but has actually still responded well. But the goal is to catch this early while they're in the fibrotic hypertrophy stage. The thickening, as with other forms of HFpEF, results in stiffening of the heart muscle. So the presentation is typical of any heart failure with preserved ejection fraction, at least in terms of the cardiac presentation. They'll be short of breath, they'll be dyspneic, they'll be fatigued, they'll be lightheaded, all the usual symptoms that we get with HFpEF. And we'll talk about some clues on various cardiac testing that'll suggest that this may be a cardiac amyloid. But in general, it's actually difficult to make the diagnosis. They look like any other PEF in many ways. And that's why it takes a long time for the diagnosis to occur. So Ian mentioned that it, on average, has taken us about a month and a half to make the diagnosis. It might be closer to 3 months now, Ian. But regardless, that's actually relatively short. When you actually look at the national surveys, it takes about 8 assessments from the first diagnosis of heart failure to the actual diagnosis of amyloid on average. And often multiple consultants end up seeing the patient before somebody clues in and say, oh, could this be amyloid? So it's not an easy diagnosis to make, partly because it hasn't been top of mind for many years, but also because it looks like any other HFpEF in many ways. So it's often underdiagnosed, and we have developed a whole program around the need to try to diagnose these patients earlier. So, as Ian mentioned, there's 2 large categories of cardiac amyloid. AL amyloid that occurs due to essentially multiple myeloma. So remember, multiple myeloma is a blood dyscrasia. It's a cancer of red blood cells where the B cells have proliferated, and they're producing abnormal amounts of antibodies that are often dysfunctional. And those dysfunctional antibodies, as I said, are dysmorphic. They start to clump together, and as they clump together, they start depositing into various organs, including the heart, and causes cardiac amyloid from AL amyloid. That's really important to diagnose because treating the multiple myeloma is obviously the key. If you don't treat the cancer, they're going to continue to produce that abnormal protein, and over time, it'll continue to damage the heart. So just treating the heart failure is not going to cut it in that setting. So that's one form of amyloid. A secondary form, primary cardiac amyloid, is called ATTR amyloid. And that's an abnormality, again, of a protein, transthyretin, which is actually the carrier protein for thyroxine, for the thyroid hormone. And so normally this protein should be carrying thyroxine throughout the body. When it becomes either genetically dysmorphic or through mutations in that individual, it again does not have the shape to carry the thyroxine hormone, and then starts to clump together and form these fibrils that then deposit into the heart. ATTR can be either a point mutation in that individual, or it can be inherited, as I said, in certain populations. So again, we'll talk very briefly about AL amyloidosis. It is, as I said, a disease of white blood cells that produce the antibodies rather than forming the normal antibodies that one would expect. That does the fighting for infections. The antibodies misfold, and then when they misfold, they start to clump together. These clumping proteins then start to form amyloid fibrils, and those fibrils start to deposit into different organs and cause the end organ damage. It's both ATTR and AL amyloid is a disease of older individuals. AL amyloid is not as old as ATTR amyloid. So, you'll start seeing AL amyloid in the age group that you start seeing these types of plasma cell dyscrasias, these types of multiple myeloma. So usually in the 50s and 60s and 70s. ATTR amyloid tends to be a little bit older than that, but it's often a disorder of an older population. For AL amyloid, the survival from diagnosis without proper treatment is under 6 months. Okay. So we need these patients diagnosed quickly, and that's why, when we see, we'll talk about the workup for suspected amyloid, but we're doing assessments. Could they have multiple myeloma or abnormal protein production like that? And then we want them in to see the cancer docs quickly. If we're going to win this, we got to get them onto treatment quickly. All right. So the delays become really important. It is obviously very important to distinguish AL from ATTR, because obviously the treatments are distinctly different. You got to treat the cancer. Focus now on the ATTR, the primary cardiac amyloid. So as I said, transthyretin is a transport protein. It's present in both the blood as well as in the serum, cerebrospinal fluid, and carries thyroxine. It also carries retinol, which is part of vision and eye issues. So when it has a function in the normal body, and it is usually a quadramer. And those quadrimers can break up so that it's not staying clumped together. But when it misfolds, either there's a point mutation and genetically inherited or in that individual, then it no longer can separate out, and then it starts to form these fibrils, and they start to clump together and then start getting deposited into organ systems that then damages those organs. As I said, ATTR amyloid two types, either wild type, meaning that it's something that happened in that individual, it's not something they've inherited within the family, or hereditary amyloidosis. The behavior of the disease is the same between wild type and hereditary. And the treatment is the same. Tafamidis works for both. So why do we make the distinction? Well, we make the distinction because obviously you want to screen other family members. If it's inherited within the family, you got to find other people within the family that may have inherited that gene, so you can start their treatment early before they actually develop the cardiomyopathy, before they develop the heart failure. So it is really important that if we suspect ATTR amyloid, it's confirmed on the various testing that we'll talk about, then we go on to that next step of doing genetic testing. It's a pain in the butt to do because it's all sent to a lab in London right now, I believe, Ian. It takes a while for it to come back. It delays the process a bit. Hopefully that'll speed up, but it is really important both for that individual but also for family members that we make sure that genetic testing is done. And if it is abnormal, our fourth one actually is a genetically inherited ATTR that we just started treatment on Ian, and I think he comes from a Caribbean Canadian descent, and so genetically we suspected that may be the case. Now we have to track down. Now the problem is most of his family is in the Caribbean, so it's going to be a real challenge to make sure that type of link is made with healthcare providers in that type of community. So as I said, two distinct types, so I won't belabor the point. It is inherited in an autosomal dominant fashion, meaning 50% of children of someone who has genetically inherited ATTR will get the gene for it, and they'll be at risk. So it becomes very important to distinguish, is it genetically inherited, and then screen other family members around them. Okay. ATTR amyloid has a slightly better prognosis than AL amyloid. AL untreated will have a survival, as I said, of about 6 months. ATTR amyloid untreated will have a few years of survival, but still it's very poor survival until newer therapies have become available. So this is the natural history of ATTR amyloid, and you can see within a few months the vast majority of people have started to pass away very quickly. And at 100 months, what is that? That's like 4 years. Not even that, 2 years, just under 2 years. More than half have died. So the mortality rate is very high for ATTR amyloid, and it becomes essential that we find these patients and get them onto treatment very early. So as I said, what are the clues that will flag for us that we need to start thinking about amyloidosis? When you have heart failure with other organ involvement, that's one of the clues. And our echosonographers, when you guys are seeing patients that you have unexplained hypertrophy, and you're in there with them for a half hour, just ask them, have they had any problems with carpal tunnel? Do they get pains in their wrists and numbness in their hands? Do they have numbness in their feet? Anything that suggests to you that they may have, and just ask them, do you have any issues with your kidneys? If there's evidence that there is multi-organ involvement, then that should be flagged. One of our heart failure nurses should be informed so that they can at least have some sort of a preliminary discussion with them and start the screening process. So peripheral and autonomic neuropathies are very common. They will develop a lot of sensory neuropathies. They'll have difficulty sensing pain and things in the feet. They will often end up with ulcers in the feet and injuries to the foot because they can't sense things. It will often deposit in the kidneys. They'll have renal impairment. It'll deposit in the GI tract. They'll have diarrhea and other GI symptoms. And so it is definitely something that we want to start looking at. Bilateral carpal tunnel involvement will again be a clue to that. And if there's a family history, if there is unexplained heart failure in multiple family members, again, something we start thinking about. One of the clues that's often the case, and actually was the case as Ian mentioned in our first case, is heart failure patients that just don't respond to treatment like we want them to. They don't tolerate the traditional treatments. They are actually very poorly tolerant to ACE inhibitors and beta blockers. They'll become really hypotensive, partly due to the autonomic neuropathy. Their nervous system is shot through the deposition of these abnormal proteins. So they'll tolerate our traditional treatments for heart failure very poorly. They respond very poorly to the therapies that we do for other types of HFpEF. So in patients, though, that have HFpEF, if they have any of these other features, it is really important that now that we have other, more effective therapies for ATTR cardiac amyloid, we start thinking about that, because we want to catch these people as early as possible and do genetic testing where necessary and start treatments where necessary. So this is really the algorithm. Now you really have to suspect it. That's the big barrier to why we're not diagnosing it. The American surveys would suggest as much as 10, maybe up to 20% of HFpEF patients may have amyloidosis. So that's a big burden of disease that we're not finding. Mostly because we're just not thinking about it. We're treating them like any other heart failure patient. We're getting them onto diuretics, whatever else we normally would do, and not really investigating as far as we need to. So, once we suspect it, it's really about, evaluating for systemic involvement, cardiac involvement, and we'll talk about how we do that, and then distinguishing which is it. Is it AL from multiple myeloma? Is it ATTR primary cardiac amyloid? Because obviously that will require different treatment. And if it is ATTR, doing genetic testing. So what are the red flags that are going to tell you this could be? Well, as I said, the history is the biggest clue. Do they have other organs involved? Carpal tunnel, numbness in the feet, kidneys, those types of things, recurrent GI symptoms, all potential clues. In terms of testing clues, so these will be people that have really thick hearts. Okay. So remember, this bizarre protein is depositing in the heart. It's causing the whole myocytes to not the myocyte, but the walls to thicken up and enlarge. So you have left ventricular hypertrophy. Normally, when you have left ventricular hypertrophy on an ECG, you'll have big voltages, right? The ECG will show giant voltages of LVH. In amyloidosis, you get the exact opposite. You have really thick hearts on an echo, but the voltages on the ECG are tiny. Okay, and it's because, remember, what's causing the hypertrophy is not myocytes, it's not muscle cells that are thickening, it's fibrosis and bizarre proteins depositing. So they're actually making it difficult for electricity to travel through the heart. And so as a result, the voltages are actually smaller. So that's a very big clue. If you have big time left ventricular hypertrophy, but really low voltages on an ECG, that should be a red flag that maybe this is amyloid and we need to start investigating that. Okay. On an echo, there are clearly a number of flags, and I'll spend a few minutes talking about that since some of our echosonographers are here, because that does become an important marker. Left ventricular hypertrophy, again, is the key diagnostic feature of this, but this thing is also depositing in other parts of the heart. So the actual valves will look thick. It'll start depositing into the pericardial space. They'll often have trivial pericardial effusions. The actual myocardium, the thickened heart muscle, will look bright and speckly. So the speckled description was one of the first descriptions for amyloidosis, was speckling of the myocytes. It's not seen in everybody, and you can make any heart muscle look speckly if you just turn up the gain too much. So you have to be cautious that you're not overcalling them. But again, there are definitely features on the echo. So increased wall thickness with a sparkling speckling pattern to the myocardium was the first description of cardiac amyloid. But it's both ventricles are hypertrophied. So normally when you get hypertrophy, it'll be in the left ventricle. It's usually due to high blood pressure, the aortic stenosis, something that causes the left ventricle to hypertrophy. But this protein is depositing in all of the heart, so it also deposits in the right heart. So getting right ventricular hypertrophy and left ventricular hypertrophy simultaneously is pretty rare. You can't really think of too many disorders that are going to cause both the right and the left ventricle to thicken up. So as a result, that should be a clue. Some bizarre protein or something is depositing in these in the heart muscle, causing it to thicken up. The atrial will enlarge. They'll start to thicken up. So again, that's a clue. And the valves, in particular, the mitral valve will look very thick and bulky and sort of amyloidish, and they'll often have small trivial pericardial effusion because the pericardial space has gotten some involvement in it. We'll talk about the apical sparing pattern that's seen with global longitudinal strain, but that's one of the new classic descriptors of it. So these are pictures that show you that. So this is a thickened heart muscle. This is a pericardial effusion at the bottom. The actual, this doesn't show it very much, but the mitral valve would look thicker. And, actually, maybe in this view, you see that. So there are features on the echo that should, again, they're not pathognomonic for amyloid. Lots of things will cause your heart muscle to thicken at the same time as causing a pericardial effusion. Heart failure will do that. Will give you a bit of a pericardial effusion. But if you see that the myocytes are speckled, the heart's thick, voltages, even on an echo, normally if you see LVH, you guys are doing, a single lead tracing to be gating echo, and normally if they're a really thick heart, you'll see that the voltages are really big on the echo monitoring that you're doing. If you see the big, thick heart, but the voltages are tiny even on the echo, again, that should be a flag. Ask a few questions around that to the patient. Do they have those other systemic features? Flag it for one of the nurses to get an ECG done at that time so we can see are their voltages low, and then we can start that process of early identification of cardiac amyloid. So this is the global longitudinal strain pictures that's now been felt to be relatively pathognomonic for cardiac amyloid. So what that means is the function of the muscle, the heart muscle, it becomes dysfunctional because of this abnormal protein deposition, but for some reason the apex of the heart is spared, so you get this what's called apical sparing or cherry on top pattern, where the rest of the mid-ventricle and the basal ventricle seems to have a lot more effects from this abnormal protein deposition, starts to become more dysfunctional, whereas the apex is spared. So when you look at that in this bullseye map, the mid portion, the apex portion has normal global longitudinal strain, so its strain is preserved, whereas the periphery out towards the base of the heart, that's where you see more of the dysfunction. So if you see that cherry on top, and that's where global longitudinal strain becomes important. And we've purchased 3 brand new echo machines specifically for this type of screening, so we can do global longitudinal strain. And so certainly for our echosonographers, again, you don't have to do a global longitudinal strain in everybody, but if you have unexplained left ventricular hypertrophy, you're seeing other features, it's a good thing to do a quick, it's automated now. I know it still adds time, but if you are suspecting it, there's other features, do the global longitudinal strain, because that type of bullseye pattern is pretty pathognomonic. There are other things that can mimic that, but the vast majority of those may be amyloid. So again, clues that we need to think about. So, Ian mentioned the nuclear scan, the pyrophosphate scan, and that's a game changer in the diagnosis of cardiac amyloid. I'm not sure why this thing is not getting out of my way. The PYP scan is a nuclear medicine scan that's readily available. All of our regional hospitals do it. Most hospitals with a nuclear medicine department can do it. So pyrophosphate scans were actually originally developed for bone scanning to look for bone abnormalities, but for various biochemical reasons, this isotope is taken up preferentially by these abnormal amyloid deposits. So it lights up the heart when the heart should typically not take up pyrophosphate at all. So it is actually very effective to do that. It's highly sensitive and specific for ATTR. The studies would actually suggest that it's as accurate to make the diagnosis of ATTR cardiac amyloid as a cardiac biopsy. And in many jurisdictions, including in the States and in Europe, you do not need cardiac biopsy to be able to initiate tafamidis or other treatments for amyloid. Right now, access is still a challenge in Ontario, and they still require cardiac biopsies, but we're hoping that that will change, and we can avoid the need for invasive testing like that, because the actual pyrophosphate scan is so accurate. So it's taken up by cardiac amyloid, specifically ATTR amyloidosis, and can reduce the need for endomyocardial biopsy. There are still cases where the PYP scan will be kind of iffy and you still end up proceeding to biopsy, but the hope is to try to avoid that. You can biopsy multiple organ systems, because remember, this is going to deposit in multiple areas. You can biopsy the liver, you can biopsy the kidney, and you can do fat pad biopsies. But all of those have a lower accuracy rate than doing a cardiac biopsy. So the gold standard is cardiac biopsy to make that diagnosis. So this is what a PYP scan would show us. So this is a normal PYP scan. So remember, the isotope was designed to be taken up by bone, and you can see bright spots in all sorts of bones that this guy might have arthritis or something, whatever he's got. So a bunch of his bony areas are taking up the PYP, pyrophosphate. In AL amyloid, so the multiple myeloma amyloid, typically the heart will not take that up, or if it does, it takes it up pretty marginally. So PYP scan is specific for ATTR amyloid. So this is a patient with AL amyloid, and again, the heart is here, and you're not really seeing much uptake of the isotope there. In ATTR, so primary cardiac amyloid, you can see here the heart really lights up. It's bright, it's brighter than other bone. This person has some other thing going on in their bone, so it's as bright as bone. So, it's very specific for ATTR cardiac amyloid and very accurate to do so. These are planar images. This is actually how you would look at it. So this is somebody that has no isotope uptake over here, and this is somebody that has the whole myocyte has been infiltrated by this ATTR protein, and it's taking up the pyrophosphate. And with that, you gate it in different ways. So you compare the amount that the heart muscle is taken up over here to the contralateral lung, which shouldn't take up any ATTR. And so here you can see very little, and then you compare what is the ratio of the isotope uptake of the ATTR amyloid area versus the lung to make that final diagnosis. As I said, the gold standard is endomyocardial biopsy. You go in, you take a part of the heart muscle, you send it for screening, and when you stain it with Congo red stain, it will show up these bright green fibrils that are depositing. So these are these amyloid fibrils that are depositing within the heart muscle, and that's what leads to that hypertrophy and the ATTR hypertrophic cardiomyopathy. So it is the gold standard in Ontario. It's still a requirement. Hopefully that requirement will change. But when stained with Congo red dye, it shows up in this green effervescent color and is pathognomonic for that. So a lot of effort, as Ian has said. It takes months to make that diagnosis, and we know these patients do very poorly. So if they do so poorly and it takes so long, why do we bother? If they're going to, why isn't it just futile, and why don't we just let all these people just lead to their natural end? Well, because it is really important to treat these patients. They have systemic involvement. They are really sick. Okay, they have all sorts of symptoms that are both cardiac and systemic. As I said, it's depositing into other organ systems. They'll be having neuropathies in their legs, hands. They'll be getting muscle weakness. They'll be in a lot of discomfort. So we need to make the diagnosis both for symptom management and for cardiac management of their symptoms. As I said, they tolerate cardiac meds very poorly. So our traditional beta blockers, ACE inhibitors, ARNIs, MRAs, often very poorly tolerated. Their blood pressure often tanks very quickly. They tend to have autonomic neuropathies. So if they stand up very quickly, their blood pressure will plummet. So getting them onto things like Entresto and things like that are a real challenge, because they just will become very hypotensive very quickly on those drugs. So that's often also a clue that if you just can't get these patients onto those types of drugs, you end up often just treating them symptomatically, keeping them euvolemic, trying to get the fluid off of them. Sometimes these proteins are also depositing in the conduction system of the heart. So the electrical flow will often get affected. They can develop heart block. Sometimes they require pacemakers. And ultimately, it's really about trying to keep them euvolemic, getting them on the right doses of diuretics. But remember, these patients are also depositing these proteins into their kidneys, so they often have kidney dysfunction. And that, again, becomes a challenge. As you're diuresing these patients, often their renal function starts to deteriorate, so they often start developing cardiorenal syndrome. So they're a very challenging patient population to manage. And none of the traditional therapies like ACE inhibitors, beta blockers, SGLT2 inhibitors that we use in heart failure, none of them have been shown to improve survival in ATTR amyloid, because you're not getting to the base cause of what the problem is, right? You're getting to the symptoms, but you're not treating the underlying cause that's leading to their heart failure. The game changer were newer therapies. So the first that got approved in Canada was tafamidis. And what we saw with tafamidis therapy in ATTR cardiac amyloid was a significant survival benefit, but patients needed to be on treatment for some time. But you often get symptomatic benefit very early, as Ian has said. Our first patient was literally in and out of hospital every 4 or 5 weeks, had multiple admissions from volume overload, and we just couldn't keep him out of hospital. Since he's been on treatment now for about 6 months, hasn't had any hospitalizations at all. So there's been huge symptomatic benefits. But importantly, if we can keep him on it, there is a survival benefit if you wait long enough. So in the first while, survival is similar, while all this protein has deposited within the heart, right? There's no magic. We're not going to get rid of this protein with tafamidis. It's not going to melt away. The body has to gradually remove this protein through recycling of proteins that happens throughout our body. So having them on treatment with time, hopefully some of these fibrils will be broken up by the body's own autolysis systems, break up these proteins, absorb them, get them out, so that the heart myocytes can start to function more efficiently. So in the first while, we do not see a survival benefit. It's really later, if you wait long enough and keep them on it long enough, that you start to see that there is a survival benefit from being on modern therapies for ATTR amyloidosis. Certainly, hospitalizations are substantially reduced with early initiation, and the earlier we can start these therapies, the more effective they'll be. Functional capacity assessments are some of our research nurses are here. One of the things that we do in measuring, for example, heart failure functional capacity is a 6-minute walk test to see how much can they functionally do. There is significant improvements in 6-minute walk test in those patients that are put on modern therapies for ATTR amyloidosis. So we are getting both functional improvements, symptom improvement, readmission reductions, and with time, hopefully a mortality benefit as well. We don't know what the final, benefits might be. It depends on when you started the therapy. Our first patient, unfortunately, was already in the dilated phase. The studies would suggest that the survival benefits are less once they get to that point of dilated cardiomyopathy. A lot of the myocytes might have already become fibrosed and scarred and maybe dead. So we may or may not get a survival benefit. We've certainly seen a significant benefit in terms of symptom relief. I've mentioned to you that this is a systemic process. It deposits everywhere. And one of the most debilitating features of this, outside of their cardiac symptoms, and they tend to be very symptomatic from their heart, is their neuropathy. So this abnormal protein is depositing into the vascular beds and compressing the nerves. It occurs in both AL amyloidosis, although slightly less, and more frequently with ATTR amyloid, so what we call primary cardiac amyloid. There's other forms of amyloid, like in the brain from Alzheimer's and things like that are not associated with neuropathies, but the cardiac amyloid, ATTR and AL amyloid, is associated with neuropathy. So what happens is these abnormal proteins start to deposit around arterioles. So they're leaching out from the arterioles that's carrying the blood. It starts to deposit around the arterioles, and with time it causes more and more fibrosis and scarring. It starts then, remember the nerves, it's a neurovascular bundle, right? So nerves and blood vessels run together throughout our bodies. And so when these weird proteins are depositing around the blood vessels, they start to then irritate and compress the nerves around them and start leading to nerve damage. And that ultimately leads to neuropathies. It leads to conduction delay. It takes longer for nerve electricity to flow upwards. You start losing nerve fibers, and remember, the body is not able to regenerate nerves, right? So if a nerve is damaged and dies, you never grow that nerve back. We don't have a capacity to grow a new nerve. So you lose intraneural connections due to this amyloid deposition. And it is a progressive process in terms of the neuropathy part of it. And it's often one of the most debilitating parts of it. They'll start off with a sensory neuropathy where they just can't sense as much. They'll start complaining that they're getting some feet numbness, their hands are feeling numb. They're, when they're trying to hold a cup of coffee, they're not holding it properly. They'll drop their coffee. They're trying to walk. They're starting to stumble. They'll often stub their toes. Just like you see with diabetic neuropathies, the manifestations can be very similar, although it can involve upper hands, upper limb as well. And, they'll start getting ulcers and things like that, start getting foot ulcers. They're at risk for amputations, all of the things that we start thinking about because they're not sensing it. So they don't even know that they've stubbed their toe and they end up with an ulcer there and that can become infected. So there is a lot of neuropathic injuries that can occur. It starts distally, meaning starts at the end of the nerves and then moves upwards. So the feet and hands will often be where they'll start off. And then, it gradually starts to progress. Ultimately, this starts affecting the full nerve system. They end up being bedridden, confined to wheelchairs. They have literally no pain sensation in parts of their body. They'll end up with ulcers all over the place. So it is a very debilitating process. The tafamidis that's used to treat cardiac amyloid has no effects, as far as we know, are pretty marginal effects on the neuropathic disease state. That's where aniline has a drug that can potentially be of benefit. So it's a really cool set of molecules. They are what are called RNA interference molecules. So remember, this is an abnormal protein your body's producing. Okay. So how is protein produced? So the protein is produced. You have DNA that's inside your cells. So the DNA from the nucleus, is transcribed to RNA, which then leaves the nucleus, then has to go out into the cell itself. There, I'm teaching you basic biology that you guys will think back to from grade 12 and early university. But so DNA is transcribed to RNA. RNA leaves the nucleus, now is into the cell itself, the main part of the cell, where ribosomes will start to translate it into making protein. Okay, but remember, they have an abnormal protein that's being produced. So if you can stop that protein from being produced, you'll stop the deposition of these weird proteins all over the body. So it's very cool that we now actually have drugs that can get to that genetic level and can target it at that genetic process. You're not actually waiting for the protein to be produced. You're actually going to stop the protein from being produced in the first place. Very cool technology. So this has been in the works for a long time. RNA interference molecules have been investigated for over 20 years. Most of them failed in most treatments, mostly because they had a lot of toxicities, often liver toxicities and things like that, and organ toxicities. But we now have the first of many drugs that'll be coming in the RNA interference pathway, where they literally will interfere with the production of that RNA, and then the RNA can't go on to producing the protein that leads to the amyloid deposition. So very cool, very interesting technology. The drug itself is called patisiran, and I think you guys market it as Onpattro. I haven't written it yet. So it's the first approved in the US. You guys have Health Canada approval as well now?
Yeah,
perfect.
A couple years.
Couple years. So this is slides that I stole from a US deck. So it was approved in the US a few years back, now approved in Canada, and at least right now has been indicated primarily for the neuropathic symptoms of ATTR amyloid. It's specific for ATTR amyloid. It targets, we won't get into the technology of where it's targeting, but it's targeting a portion of the mRNA that leads to that abnormal protein formation. So you're shutting that down, so you're forming less of those proteins, less will deposit and ultimately lead to less nerve damage. They have good data that I won't get into in terms of their neuropathic symptom relief, but interestingly, they also have good data that's starting to come together that it may actually be of benefit even in the cardiac manifestations of amyloid. So it may reduce the deposition, which makes sense. If you produce less of these proteins are produced in the liver, there's going to be less circulating in the bloodstream, less will start depositing into every organ system, less into your nerves, so you're going to get less nerve damage, but less into your heart as well. So you'll get less myocyte injury and less cardiomyopathy formation. They don't have an indication for cardiac treatment. Their indication right now is really around treatment of neuropathic symptoms, but if the data continues to build, my expectation is that we will have a series of drugs that will allow us a very effective treatment. So to finish, I think the key message that I want to end with is we got to find these patients, right? That's the big challenge. It is a very underdiagnosed condition. If the American data set is correct, that as much as 10 to 20% of HFpEF patients have amyloidosis as the cause of their HFpEF. How many thousands of heart failure patients do we have, Ian? And we have 4 on treatment for amyloidosis. So clearly we're not finding these patients yet. It's an all hands on deck approach. Anyone that suspects it needs to start thinking about it, needs to initiate the workup of it. It takes time to make that diagnosis. Even in the fastest approach, anywhere for us between a month and a half to 3 months. But our first patient was in and out of hospital for heart failure for many, many months before somebody clued through to say, could this be amyloid? And then the process started. So it is about thinking about that. This is now a class 1 indication for screening. So remember, guidelines have multiple levels of recommendations. So class 1 means it is absolutely mandatory that you do this because the impact of treatment is so high. It's not questionable. It's not if you feel think about it that day and you decide to screen for it. Class 1 indications mean that they are absolutely indicated that we should be thinking about this. And so this now has a class 1 indication in the American Heart Association, American College of Cardiology, screening guidelines for HFpEF in patients that have suspicions for amyloid. So they have those systemic features. They have unexplained left ventricular hypertrophy. They have, other parts of the clinical features. We should be screening for both AL amyloid. That might tell us they have multiple myeloma. How do we do that? We do that by sending them for serum and urine electrophoresis and immunofixation. So you're trying to find these abnormal proteins that the beta cells are producing, and they'll be in the urine and in the serum. So that's how you make the diagnosis of multiple myeloma. So they need to be screened for multiple myeloma through serum and urine immunoelectrophoresis. Then, if it's not that, and now you're thinking it might be ATTR, so primary cardiac amyloid, they need to have that PYP scan. It is, as I said, almost pathognomonic. If that bright heart shows up on that PYP scan, there's almost nothing else that can do that. So it has a very high sensitivity specificity rate. Most jurisdiction, that's enough. That gives you indication to start treatment with ATTR-based therapies. In Ontario right now, it still requires that 3rd step of getting a biopsy to confirm it. Once the biopsy is confirmed, the government actually pays for ATTR therapy right now. So it is covered through special forms and all this nonsense that, again, takes weeks to get through the process. But there is a process in place. It takes a bit of time. It requires motivation, both from the patient to go through all this testing and from the healthcare providers to stay motivated that we have a treatment that will save lives. And certainly once we have that diagnosis that they have ATTR, remember this can be a genetic disorder in some individuals, particularly certain clusters. The African Canadian population, the Caribbean population tends to have higher rates of that. There's some talk that the native Canadian population may also have higher rates of ATTR. I haven't seen compelling data on that yet, but certainly all of these patients that have a diagnosis of ATTR, we should be sending them on for genetic testing, because if they have the genes that cause ATTR, then we need to then screen family members, catch them early before they actually develop the cardiomyopathy, because the earlier we can start the treatment, the better the overall survival benefits that may accrue from that. So that's a long talk after a very brief presentation that Ian gave us that was much more succinct. But I think the key thing is that we need to make this top of mind. We need to think about it in the right patient population. There are clues. The history is by far the biggest clue. If they have systemic features, they have numbness in their feet, they have neuropathies, they have carpal tunnel, they have concomitant renal dysfunction, and they're in heart failure, bells should go off saying, okay, could this be amyloid? We need to start screening for that. Similarly, if they have big, thick hearts on an echo, but their ECG voltage is tiny, that doesn't make sense. If you have LVH, you should get huge voltages on your ECG. If you don't have that, that should be a clue. Maybe they've got amyloid. Could be other things. It could be pericardial effusions, things like that can make voltages smaller. But again, infiltrative disorders like amyloid Fabry's, sarcoid, all of those types of things will shrink the voltage, and again, clues that we need to think past just, oh, this is a standard HFpEF patient. We go past the treatments that we've used traditionally for HFpEF populations. So at that point, I'm going to stop talking. I will open up to our guests that may have some other things that they have some thoughts that they want to talk about.
I have to say, I've sat through a lot of education programs. That's one of the clearest, most succinct presentation I've ever heard. It was really great.